Hi, I'm Captain Kate Cahill from your Access QA department. Today I'd like to talk to you about the importance of proper documentation of two different high liability call types: law enforcement assists and domestic violence and assault cases. Hopefully I can provide you with some beneficial information that will explain why these responses can no longer be written as no patient charts within the Access system. Increasingly, cases are being requested where there is evidence crews have arrived on location and provided some level of assessment and questioning, but no chart was written, or rather a no patient was written, with little to no information if the individual declined further care. As these are highly litigious cases and happening more and more frequently, the standing written orders have been updated to include the following patient definition in Protocol G9, patient refusal and documentation. Among other things, a patient is an individual that law enforcement personnel have requested be evaluated by EMS. Consent to physical assessment or treatment must still be granted by the individual. In the event the individual is in custody, the officer or deputy may consent to refuse evaluation, treatment, and/or transport in behalf of the individual in custody. Note, this does not preclude access providers from making a patient-specific chart if they refuse care. Further, the protocol states a patient is an individual that is a possible victim of intimate partner violence, domestic violence, sexual assault, strangulation, or any other form of battery. As you can see, these call types now require a completely different chart and no longer qualify as a no patient. While the reasons we are called to evaluate these patients remain largely the same, the environment in which EMS, fire, and law enforcement operates continues to evolve. Today, often crews function within a fishbowl of public scrutiny. Cell phones, on-body video cameras, and social media outlets contribute to this. While daunting, you can work in this environment with confidence by always acting in the best interest of the individual you are called to help in mind, and writing the PCR accurately to reflect the care you provide. These scenes can be chaotic. In the case of an individual law enforcement has called us to evaluate, that person could be violent, uncooperative, or not forthcoming. In a domestic violence situation, victims may be fearful, avoidant, or distressed. These situations create a sometimes challenging environment, to say the least. That's why it's so important we ask the appropriate questions and document the call to the best of our ability, even if it's only what we can see and hear. So let's dig in. Let's talk about law enforcement evaluation requests. First off, access providers cannot medically clear an individual in the field. Medical clearance must be performed at an appropriate medical facility. EMS and fire crews can assess and provide objective clinical findings to the arresting officer, so they may make the determination for what happens next. In Idaho, a law enforcement officer has the authority to make medical decisions for individuals currently in custody. If the individual is being detained, they still maintain their own medical decision-making power and can accept or decline evaluation or care. Check with the lead officer involved to find out their custody status. Regardless of their custody status, if you're unable to perform a physical assessment or obtain vital signs, a visual assessment will suffice in your chart. Is that person awake? Alert? Is their airway patent? Are they talking or yelling? Are they moving their extremities in a coordinated fashion? This helps paint a picture of the patient's appearance without a hands-on physical exam. Information given to you by law enforcement, the patient, other responders, and perhaps bystanders or family, if appropriate, should be part of the narrative of your chart. That becomes particularly important if you're called to testify in court. The takeaway with documenting law enforcement assist calls is this: your goal is to provide medical assessment and care to the individual in custody or detained, and give the primary officer involved objective findings and information he or she may use to determine the next appropriate step. The second situation I'd like to discuss is response and documentation of victims or suspected victims of domestic violence or assault. These scenes can be very difficult for everyone involved. The individual who's been harmed may be afraid, non-cooperative, or avoidant for a multitude of reasons. It's extremely important to approach these cases in a non-judgmental and supportive fashion. Again, if the victim you're called to help insists they do not want assessment, care, or to provide information, that's their right. We certainly do not want to bully or pester people in these circumstances, but do try to let them know in a caring manner that you're here to help. If the patient does not allow a physical exam, that's okay. Just document what you can visualize from afar and explain in your chart the reason a physical exam was not possible. It's important to note the relationship of the aggressor to the victim in these cases, if the victim shares that information with you. Was it a stranger, an acquaintance or family member, a spouse or a partner? Any other information shared by the victim, law enforcement, or bystanders should be documented in the narrative as well. Basic demographics should be included when possible. Vital signs, medications, medical history, allergies should also be included if the victim allows you to obtain them. If the offer of transport is refused, obtain a refusal signature with a witness signature whenever possible. If that's not feasible, document the attempt and why it was not successful. Make sure any potential victim understands there are resources to help, and they can call back EMS at any time should they change their mind. As public safety providers, we are compassionate people. Make sure your chart reflects the level of care you're providing in these situations. Maybe folks don't really understand the impact they have as a medical authority on these difficult scenes. We have examples where our providers really have made a difference in a victim's life by their attention to detail in the patient care report. So to sum it up, law enforcement assists and domestic violence or assault calls are no longer no patient charts under the Access Standing Written Orders. Make sure the care you provide or intend to provide is well documented in these cases, as it can make a difference for everyone involved. And lastly, make sure the chart you write accurately reflects your care as a medical provider. A clear, complete, and well-written chart speaks to your professionalism when presented to an attorney, physician, or any other person requesting it for review. Thanks for watching. Please contact the Access QA department with any questions or concerns. I'm Captain Kate Cahill, and this has been another episode of Access Documentation Minute.